Welcome to the Mamatoosa podcast. I'm your host, Atusa Benji. Hi, welcome. Welcome to the Mamatoosa podcast. My name is Atusa Benji. I'm a licensed midwife, mama and grandma, and educator. And today I want to talk to you a little bit about our medical system and birth work in general, the difference between certification and licensure, and it's different around the world also. So we'll talk about that. But we can't understand the present unless we know a little bit about the past. And obstetrical history is dark. It's dark when you really go back and you look at what happened to midwives, what happened to women who were taking care of women and catching babies and working really hard to pass on midwifery as an apprenticeship and as a legacy. A lot of those people got completely wiped out by essentially propaganda that came in and said that midwives are dangerous and dirty and uneducated, and they'll kill you and they'll kill your baby. So let's talk about a little bit about how that happened. So essentially, women have always been helping women have babies. It's a tale as old as time. You got pregnant at some point. No one really knew exactly what their due date was. There was no app. There was no measurement. There was no ultrasound. You would likely miss your period and your belly would start to grow. And lo and behold, you were pregnant. And it would be guesstimated then that by some other woman, whether she was taught to be a midwife or whether she had a lot of experience because she had a lot of babies herself or both, would touch your belly and say, oh, about 3 weeks or 3 months or 6 months. And your baby will come in the spring. Your baby will come at the end of the summer. Your baby will come in the beginning of the new year. But there was this concept of your due date is March 13th, blah, 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 which we'll also talk about induction and stuff in other episodes. But midwives essentially had training, on-the-job training, over and over and over again through the apprenticeship model, which worked pretty well because grandmothers would pass it down to mothers and mothers would pass it down to daughters. And essentially midwifery, I always say that sometimes I look at some of my friends who are midwives and it like runs in their veins, it runs in their blood. And when you ask them, they'll be like, yeah, my grandma was a midwife, or my great grandma was a midwife, or we're all midwives. It's passed down generationally, the essence of being a birth worker. But back in the day, you didn't go to school, you didn't get formal training, you didn't get a degree or a license, but you were typically very good at what you did. Now, did people get sick? Absolutely. Did babies die? Absolutely. Did mothers die? They did. And in those days, they didn't die because of midwifery care. They died because of the lack of prenatal support, education, and care. And they died because of lack of sterile technique. And they died because we were more prone to diseases and illnesses that have now been eradicated. So when we talk about the safety of obstetrical care versus the safety of midwifery care, and you say, yeah, but people died in those days. People died in those days not because the midwives didn't know what they were doing, but more people died in general, more babies died in general, and people didn't have as long as a lifespan. So yes, more babies died in those days. But up until right around the 1500s or so, where formalized medical education started coming in, women helped women have babies, and most people did pretty darn well. When medicine became formalized and people started going to medical school, typically men went to medical school, and typically people who could go to medical school went to medical school. Usually people who had the money to go to medical school, who could afford to go to medical school, who had the privilege of going to medical school, usually wealthy white men. And they studied medicine. And as we know, it's called the practice of medicine because we don't know what we know. We didn't know what we knew now 40, 50 years ago, or 400 years ago, or 4,000 years ago, and likely in 40, 50, 400, 4,000 years we'll know more. But the practice of medicine often was on human beings, where we realized that that's probably not a good idea, or that works really well, let's implement it, or yeah, let's not do that again, that wasn't good, that was killing too many women. But essentially, a doctor was the family care provider. So there was one doctor, and that doctor took care of delivering babies all the way up to people dying at the age of whatever they died on their deathbed and everything in between. So essentially a family medicine physician. But it wasn't until later where obstetrics actually became its own specialty, and doctors became fascinated with the pathology of pregnancy and the pathology of childbirth, and how are we going to get this baby out of this body in the best way possible. And it became a science, and forceps were introduced, and medication was introduced. And some of our darkest history was during the 1800s, where a lot of experimentation was actually done on female slaves against their will, without anesthesia, where obstetricians literally practiced on their bodies, namely Dr. Sims, who was actually very famous for understanding and creating the surgery that fixes fistulas. And a fistula is an opening between two organs. So when a woman had a obstetrical complication and there was essentially a hole between her vagina and her rectum, he was the one that was like, okay, what's the best way to fix this, to remedy it? He was a surgeon. He did some good work, but he also has been written up for some not great work and some straight up abusive work against women and against slaves who were not able to give informed consent, and who he did numerous experimentations on. And they were not alone. But right around the mid 1800s, doctors started thinking, okay, how are we going to eradicate the pain of childbirth? And right around that same time, a lot of propaganda was being spread about midwives. So the notion of having your baby at home was looked at as for poor people or for uneducated people. If you were wealthy and smart and you had the money and you had the know-how, you would go and have your baby in a hospital. And in the hospital, you would have painless childbirth. Let me tell you a little bit about painless childbirth. The first medications that were used as anesthetic for painless childbirth were ether and chloroform. And both are horrific medications that essentially put women out. And so a woman would be in labor, she would get close to delivery, they would give her ether, and she would black out, and she would not remember anything, including the birth of the child. And essentially a woman who is on ether is unable to push out her own baby effectively, which is where the episiotomy comes in, which is a surgical incision that is made at the vagina towards the rectum to make space to often grab forceps and pull the baby out because the mother was out. And so this was some of the rhetoric of, let's leave those dirty, uneducated, baby-killing, mother-killing women behind and come and have your baby in the luxury of painless childbirth at the hospital, where your physician who has gone to medical school will take care of you. In parentheses, who's still practicing obstetrics. Ethically or unethically, there was a lot of practice going on. Interestingly, what I always talk about with colleagues and physicians is that when it comes to childbirth, we actually haven't made that many advances. We have vacuums, we have forceps, we have cesarean section, we have sterile technique, we have antibiotics, thank God. But when it comes to the actual baby coming out of the pelvis, out of a vagina, we haven't made that many advances. So the midwives of back in the day who had training from the women who came before them really had art that we don't have. Right here in California, if your baby is breech, you are going to be hard pressed to find a doctor who will help you have a vaginal breech delivery. A couple podcasts down the road, we are going to have a guest who had a vaginal breech delivery very successfully, but she had to go to many lengths to make the universe line up so that there was a provider who would take care of her to do that. And those physicians are few and far between, because at one point in time, we decided breech vaginal birth was dangerous. We should stop doing it. The babies died. The mothers died. We stopped teaching it in medical school. And only physicians who really want to learn the art of delivering a breech vaginal baby have to go to extra measures to learn with an instructor who will train them in that way. But it is not part of routine training anymore. So our breech babies are typically being born by C-section, not because all of them have to be born by C-section, but because we stopped teaching it. But back in the day, your midwife had knowledge of herbs. Your midwife had knowledge of nutrition that came from whole foods and from plants. Your midwife would have knowledge of how to deliver a breech baby, what to do with a baby that wasn't coming out well. One of my favorite stories of my country where I was born was a very old midwife who lived in the Jewish ghetto, and she was actually blind. And she had mad skills, and she was able to successfully manage some of the biggest obstetrical complications just with her hands and her training and her knowledge and her intuition. And the fact is that the king's wife, the queen, was in labor, and she was having a very, very difficult delivery. And all of the doctors were around her, and nobody was able to help her. And she was close to dying and close to losing the baby. Until one said, listen, there's this midwife. She lives in the Jewish ghetto. We can go get her. She's super old. She's blind, but she knows her stuff. Let's get her in here. So they go by white horse in the middle of the night, and they bring her to the palace. And she feels around and she says, bring me ice. And back in the day, they didn't have freezers, so you would open the ice and grab some ice from the ice maker. It was an ordeal to get ice. And to get ice now in the middle of the night? Yes, go bring me some ice. So they go bring her ice. And what was happening was that the baby was coming out in what we call a compound presentation, which means the baby's hand was in front of the baby's head, which actually makes the diameter bigger and makes birth more difficult. So essentially it was obstructed. So she took the ice and she put it on top of the baby's head. And when the baby felt the coldness of the ice, the baby retracted the arm and the head was able to be born without obstruction. That is some common sense happening. But yes, if you put cold ice on someone's hand, they're probably going to move their hand away. But she had that knowledge and was able to save the prince that was born that night. But she was one of many, of which I wish I had all the names, but more and more I hear my great grandmother was a midwife. This is what she did. This is what she did. I was at dinner the other night with my cousin, and her husband said, did you know my grandmother was a midwife? And I'm like, no, you never told me. She's like, yeah. Sometimes I'd go stay with her in the summer, and she'd wake me up in the middle of the night, and she would say, grab my bag, let's go, a baby's coming. And he would help her sterilize her instruments as a little boy. So the legacy of midwifery is huge and fantastic and honored, but we lost it. And we lost it to this rhetoric of doctors know better. Women should no longer have this skill. And in the darkest of history, women were actually killed. Midwives were called witches. They were burned at the stake. And there's a lot of politics when it comes to women providing care for other women that gets into birth justice, gets into reproductive rights. And so birth by nature is a political issue, especially where we live. Again, more on that. There's so much to talk about. But when you talk about the history, midwifery began to be obliterated and doctors began to take over. And not because it was better, but because they said it was better. So there was chloroform, there was ether. There was a time in the United States where women were caged and restrained to their bed with leather cuffs when they were delivering babies in the hospital. And this was right around the 1940s. Rest her soul, Penny Simkin, one of my mentors, talked about it and wrote about it in a lot of her literature. But what happened was that twilight sleep came about. So ether and chloroform went out of style, and we now brought on twilight sleep. And with twilight sleep, women were no longer completely knocked out, but the medication in the twilight sleep made them so agitated that they would have hallucinations, and then it actually didn't help much with their pain control either. And then they would attack the nurses and the doctors and the care providers who were taking care of them. So at one of the darkest point in our history, women were restrained to the bed and they were put in cages while they labored, because the medication that we were using for painless childbirth, because midwifery in the home setting was dangerous, was causing this to happen. And it wasn't until women started writing in to magazines and newspapers and shows and saying, I was caged while I was giving birth. And a lot of this stuff people don't know. People think, oh, pregnant, doctor, labor, hospital, that's where you have your baby. Why would you do it any other way? But what I'm beginning to see and what I'm beginning to know is that many times in our current medical system in 2025, we will take a perfectly healthy woman who is in her 20s, has zero medical complications, has this beautiful pregnancy, put her in the hospital, and inherently increase her risk just by the decisions and the protocols that we have in hospitals. And I'll explain more to you why that is. So by the 1940s and 50s, midwives were almost completely obliterated. And just to go back, talk a little bit about enslaved women in the United States, helping other women have babies. Well, they brought that training from their countries that they were taken out of to become slaves in the United States. So that was immigrant women, Black enslaved women who were catching the babies on the plantations and in the homes where they worked, not only for fellow slaves, but also for masters' wives. So the irony of being taken out of your home, out of your country with this incredible skill that you have, to then be a slave and then have to take care of your master's wife. And often a lot of those pregnancies of the enslaved women were the results of rape, which we know the history of the United States and slavery and Black women. But essentially, those were the women with the skill. Those were the ones with the talent, until doctors decided, family medicine, let's also have a specialty called obstetrics, and we can have a specialty and figure out this pathology of childbirth. And doctors like Sims and Smelly, his name was Smelly, and DeLee were some of the first to make great leaps and bounds in the field, but not necessarily to the advantage of the women who were giving birth at that time. So home births went away. Midwives mostly went away. They were literally obliterated, and people started having babies in the hospital. And so there was a time in history, like towards the 1960s and 70s, where midwives were like, you know what? We got to get this midwifery thing back up again. And in Europe, if any of you have watched Call the Midwife, there were nuns who were being trained as nurses and then being trained as midwives and practicing as midwives in the communities. And by the time World War II rolled around, in London, the majority of births were attended by nurse midwives, either through training of the church or they were actually nuns themselves. In the United States, midwives and women started saying, what about midwifery care? What about home birth? What about taking birth back into the hands of women, which got a tremendous amount of resistance from the medical setting, again, under this umbrella rhetoric of Home birth is dangerous. If you want to have a safe birth, a clean birth, an educated birth, come to the hospital. Statistically, we know that an unmedicated vaginal birth for a low-risk woman at home who has proximity to the hospital has better outcomes than the same for a woman having a baby in the hospital. And many episodes are coming that we're going to talk about all the nitty-gritty and the different types of birth. But when you look at the safety of home birth, the safety of midwifery care resides in number one, proper prenatal care. Educating women about their health, about their nutrition, about exercise, about stress management. A woman who is carrying one baby is much lower risk than one carrying twins, although midwives of back in the day delivered twins beautifully with the knowledge that they had and the skill that they had. So when you talk about a home birth, your scope of practice as a midwife has to be a low-risk woman. No hypertension, no insulin-dependent diabetes, only one baby, not more than one baby in there, and no underlying conditions that are going to cause this birth to be higher risk when it comes time to labor and delivery. That is where doctors shine. Doctors shine in taking care of the higher risk woman. If you're an obstetrician, thank God you have the skill to do a C-section, to manage inductions, to take care of women who have had difficult gynecological pasts and histories and difficult births. That's what our doctors are for. And I'm grateful for them. I work with them. I collaborate with them. I honor them. But the system as a whole isn't doing women justice by telling everyone that hospital birth is inherently safer than home birth. And we can look at the history and see what happened. So by the 1980s, we started having more midwives. There was laws that went into place through tremendous hard work from women who went to lobby for midwifery care, went back to make midwifery legal, went back to make home birth legal. In many states of the United States, if you practice midwifery, you will be sent to jail and you will be accused of practicing medicine without a license. In many states in the United States, midwifery is legal, but it has a lot of parameters around it. Here in California, we are blessed. So I'm going to tell you a bit about the differences in midwives in California. Here in Los Angeles, where I'm sitting, we have essentially different types of midwives. So you can be a midwife who has excellent training, but never went to school and never got licensed. And there are people who choose those midwives, people who trust those midwives, and those midwives have excellent, excellent skills because of the training that they've had through the apprenticeship model, even though they never formally went to school and even though they don't have formal licenses. If they are caught doing this, there could be charges against them, but that doesn't mean it's because they don't know what they're doing. It's because many people don't have access to school, don't have money for school, don't have the luxury of having time to go back to school, and are still serving their communities effectively and really helping the areas that they're in, especially rural areas where hospitals and doctors are few and far between. Then we have the certified nurse midwife. And that came about when people started saying, we need midwives, bring our midwives back. So the medical establishment said, you know what, fine, no problem. We will bring your midwives back, but only if they work under doctors. And what we know in the hierarchy of hospitals, nurses typically work under doctors. Hospitals, doctors are like the highest on the chain of command, and midwives typically work under doctors. That's how it's sort of set up. So they said, fine, take the nurses and give them some extra training and make them midwives, call them nurse midwives. We're cool with that. And so nurse midwives started to be trained. And a nurse midwife is someone who has gone to nursing school, gotten either their associates or their bachelor's or their master's in nursing, and then they go to school for 2 to 3 more years to get a master's in nurse midwifery. And so a certified nurse midwife called a CNM has privileges that could be in the hospital setting, but they can also do home births if they choose to. And some of them even work in birth centers. So certified nurse midwifery allows for uncomplicated, low risk birth that is managed from beginning to end by a midwife. And that's something that a lot of people don't know. People think that a midwife is like some old, witch old lady looking person who brings crystals and a broomstick and a black cat and a cauldron to the birth and, says some magic words and then babies come out. Sometimes we do that. Just kidding. But the certified nurse midwife is one path to midwifery in California. The other path is the licensed midwife, because again, through the work of advocacy and women who went and fought and lobbied and said, you know what, why do you have to be a nurse to be a midwife? Why do you have to have a nursing degree in order to practice midwifery? And the answer is you actually don't. In most countries of the world, get this, in most countries of the world, midwifery is direct entry. You do not have to go to nursing school to be a midwife. But here in California, here in the United States, that is a path that is open to people. But it's not the only path. So, licensed midwifery. A licensed midwife is someone who has attended an accredited midwifery school, gotten their midwifery education, and then has worked with midwives in the community, either home birth setting or in the birth center model, and learned how to catch babies, manage obstetrical complications, draw blood, order labs, start IVs, resuscitate babies. Did you know that midwives will actually suture? Because sometimes women tear during childbirth, or sometimes an episiotomy rarely has to be done. And we need to know how to suture. Many people don't know that. Many people don't know that when it comes to home birth, we are the resuscitation team, we are the suture team, we are the IV team, we are the nurse and the doctor and respiratory therapy all rolled into one. So in the licensed midwifery model, you don't have to attend nursing school. You go to direct entry midwifery school, you practice in the community setting, and then you take a board exam. So licensed midwives are licensed by the California Medical Board here in California, and every state has its own legislation because of the politics in midwifery. So here in California, as a licensed midwife, I can provide prenatal care for 9 months to low-risk, healthy women who wish to have an out-of-hospital birth. Can I work in a hospital? I can, but most hospitals are hiring nurse midwives for some of the reasons that we talked about earlier. But there are parts of the United States where licensed midwives are working in the hospital setting. So healthy women, low-risk women, knowledge on education, stress management, the family setting. We have long prenatal visits, sometimes going over an hour at a time. We see people the same schedule as obstetricians see people. So every month for the first 28 weeks. After 28 weeks of pregnancy, we see people every 2 weeks. And after 36 weeks, we see people weekly. And then after 40 weeks, once to twice a week, depending on what's going on. Our scope of practice is to catch the babies that are born between 37 and 41 weeks and 6 days. So if you go into labor at 36 weeks, it's out of scope. We would come with you to the hospital with a collaborating physician, and you would have your baby in the hospital. Or if you go past 42 weeks, then that is also out of scope. We have very strict parameters. What's your blood pressure? What's your blood sugar? Is the baby head down? Is everything normal with the pregnancy? If anything starts to be off, we have physician collaboration that tells us still safe for a home birth or not safe for a home birth. We're also moving away from calling home births. We're moving more into community births because that's really what it's always been. Babies are born in homes, in communities. So community midwives are serving communities at home and in birth center settings. And we have parameters, and by the grace of God and the miracle of birth and the way that the human body works, we have low transfer rates, we have low C-section rates, and we have low rates of complications. You might ask, what happens if there's a complication? The number one question someone asks me, Atusa, you deliver babies at home, isn't that risky? Birth is risky, y'all. Birth is risky. Whether it's at a hospital or it's at home, there is risk associated with birth, period. But as midwives, yes. Do we manage shoulder dystocias? Yes, we do. Are we trained in it? We absolutely are. Can we manage hemorrhage? Yes, we can. Do we bring medication for hemorrhage? Absolutely. Most of us carry 3 to 5 different medications for managing hemorrhage, including Pitocin, including Cytotec, including Methergin. We can all set up IVs, hook up IVs, and then seek the adequate help to get to the hospital for hospital care to take over. Many times we manage hemorrhages at home and moms do just fine. We manage shoulder dystocias at home and babies do fine. We know how to handle codes. We have the training and the knowledge to manage low risk deliveries. And if complications happen, we are trained to manage them. Now, in the case of something that happens that is out of our ability to manage at home, we call 911 and we go to the closest hospital and we go with the client in the ambulance, and we are actually working with the paramedics to manage the obstetrical complication until we get to the hospital and the hospital team takes over. The other thing that midwives have is continuity of care. Typically, if you are with a doctor, sometimes your doctor is in a group and you'll see one doctor, you'll see another doctor. There's no guarantee of who's going to be there. Also, you get to the hospital, you have different nurses. You don't know who your nurse is going to be. And nurses change shift every 12 hours. Midwives don't. When we go to a birth, whether it's 13 hours or 33 hours or 53 hours, we have typically had continuity with you from right around when you conceived or when you came into care all the way to 6 weeks after, during the postpartum period. So we are licensed, whether licensed midwives or certified nurse midwives, to take care of low risk, uncomplicated pregnancy for 9 months. We also catch your baby. We never say we deliver babies. The mothers deliver the babies. We catch the babies. And that really gives honor to the person who is delivering. I'm no superstar who shows up and delivers a baby. I'm honored to hold space and bring some education to what is happening at the birth. But I catch the babies and hand them typically to the person who delivered them. We also take care of people in the immediate postpartum period. So we stay for about 4 hours after the birth and make sure that mother and baby are both stable. We do a full newborn exam. We come back in a couple days and we do the metabolic blood draw for the baby, which means we prick the heel and we collect blood if the family has consented for the blood to be sent to the state and checked for metabolic disorders. We also continue checking the mother's labs. If we need to do blood draws, we can. We all have lab accounts that we're set up with. Many of us work with gracious, kind, lovely obstetricians in the community who honor our work and respect our work and trust us, which the key to a safe birth is trust, whether it's between client and midwife, client and doctor, but also the team, the midwives and the nurses, the midwives and the doctors, and the whole team coming together. That's really where it's at, is the safety and collaboration, honor and respect for the entire birth team. So we're also checking up on breastfeeding. We're also weighing the babies. We always ask that a pediatrician sees the baby in that first week or first few days after birth, because we're not pediatricians, we're not doctors, we don't claim to be, but we are experts in what we do. We are educated, we are licensed, and we provide community care at a very, very high standard with very, very good outcomes. I hope you watch many of my podcasts and listen to many of my podcasts, and together we will go through many stories and all different lessons that come from this incredible journey. See you soon. Thanks for listening to the Mamatoosa podcast on the Industry Plant Podcast Network. Mamatoosa is hosted by me, Atusa Benji, and produced by Josh Stretton Carlson. Chris Agnew is our audio editor, and our theme music is composed by Mary Lalazarian. If you enjoyed the podcast, please consider leaving us a review and subscribing. See you next Tuesday.